I just wanted to take a moment and thank all the participants for joining. We're really excited to launch this initial webinar. We are really grateful to have an expert panel joining with us today, and I think that's really the power of this. And just as a quick introduction, my name is Vijay Agarwal. I run the Skull-Based Center at the Albert Einstein College of Medicine. And this webinar really addressed the questions I had during training. NASBS has been critical, I think it's fair to say, in all of the panelists' careers. It's been absolutely critical in mine. I really wanted to help put this together with the help of NASBS. And we're very grateful to welcome Phil Theodosopoulos, Dr. Theodosopoulos. He's a Vice Chair and Director of Cranial Services and Residency Program Director at UCSF. Lee Zimmer, Director of Otolaryngology at Mercy Health, as well as Mayfield Brain and Spine, talking about their early experiences putting a skull-based center together. Paul Gardner, he's the Peter Janetta Endowed Chair in Neurosurgery, Professor of ENT and Neurosurgery, co-director with Dr. Schneiderman of the UPMC Center for Cranial-Based Surgery, and the Executive Vice Chair of Surgical Services in Neurosurgery. Dr. Schneiderman, as I mentioned, is the co-director of the center. He's also professor of otolaryngology and neurosurgery. He's also the vice chair of quality and safety for ENT. From Michigan, we have Dr. Erin McKean. She's the dean for medical student services, the associate chair for clinical operations. Sullivan, he's the associate professor in ENT neurosurgery, neurology, and the director of the panelists we have here. Is they've been instrumental in a lot of our experience getting into skull-based, but the centers, I think, are at different places. I'm going to go ahead and share my screen here as well. Hopefully that shows up okay. And it really is the impetus for this comes from, when we start training, we start as undergrads, and there's a very clear pathway to success. You need a good MCAT score to get into medical school. You need a good step 1 score to get into residency, from senior residency to fellowship. So for decades, we have a very defined path in terms of success, metrics for success. When you decide you want to do a skull-based career, that's sort of where the guidance ends. And that's the goal of this panel. How do you build a skull-based team? How do you build volume? How do you gain experience? What obstacles will you face? Who do you turn to for advice? And who are you in this field of neurosurgery? What do you have in terms of identity? And I think that's the biggest thing. Within neurosurgery and ENT and all the subspecialties within skull-based, I think you really need to find something that's unique. Sure. Got a comment. I just want to make sure everyone can hear okay. And skull-based teams on the panel. And we've learned a lot in our few years starting the skull-based program here at Einstein. And these are some of the lessons that we've come away with. There's been bumps along the road, but we really wanted to express in a really frank manner some of the things that we've learned. And I think the first thing is that there's really no I in team. It really is a team sport. You really can't do skull-based in isolation. And what we did is I was lucky to come into a program where there were experts in each of the specialties in their field. They just weren't working together in the field of skull-based. And we found that getting these people who were experts in their individual fields excited about things in skull-based really led to success of the center. So we had our endocrinologists work on IPSS sampling. We had our neurooculoplastics surgeons. They were interested in tones. So we brought that to Einstein, and that really helped us in a center as a whole. The second thing I really wanted to reiterate is that numbers really don't lie. When I came in 2018 to Einstein, we had a big academic center, but we were really losing a lot of volume. 50% of our skull-based volume was going to other centers in Manhattan. 20% was being lost to radiosurgery that we thought were operative cases, and 30% were being surveilled. And so I think you really have to know where you're losing the volume before you can address it. We went from a handful of cases a year to about 175 cases per year, and we really focus on metrics. We're really a metric-oriented program. So besides the cases, I think it's really important to focus on the complications as well. So we really monitor things like CSF leaks and readmission rates and things like that. And I think it's very, very important to follow those things. Otherwise, there really is no clear mark of success as a center. The third lesson we had, and we learned sort of the hard way, is that one size never fits all with a skull-based center. Two of the people I think are the most technically brilliant surgeons I've ever trained with are Mike Link and Charlie Teo. And I think, just as they're brilliant, they're very dogmatic in the way that they approach neurosurgery. And I think their outcomes were outstanding, but they approach cases very, very differently. And I think that goes to show that there's not one specific approach to a tumor that's considered successful or the right way to do a tumor. I think there are different approaches or different ways that you can accurately approach a brain tumor. And when I was first came to help build the center here, I was convinced that we were going to become a minimally invasive cranial-based center, but that changed based off our pathology. We noticed a very sort of large percentage of high-grade invasive meningiomas, so 50% of our operative meningiomas are high-grade. And I think that just speaks to the patient population who present later in their disease progression. Many of these presented with advanced disease, and we found that a combined sort of multiportal approach is the best way to approach these. As I mentioned, a lot of these cases were getting radiated before we started in 2018. And so we had a lot of breakthrough growth in these tumors that had gone through hyperfractionated or SRS. So a lot of these required sort of larger, bigger, multiportal and combined approaches. In terms of our anterior skull-based program, it was a similar story. And so there were a lot of redo cases and biopsies from centers that were in the community. And so our identity really became defined by these open and endoscopic combined approaches, and we really embraced that. It was a totally different mission than we had started out with, but all of our talks, presentations, and publications really focused on this, and we wanted to make sure that we were presenting with a very similar message. Sort of just to kind of wrap up here, I think every center needs to have a mission, and in terms of our center, we realized that it was really important to have an overarching theme. And for us, it turned out to be education. Our residents, before we started, were having problems making pituitary numbers and those sorts of things. So we took it as a ground up approach. So we started cadaver dissection, skull-based monthly skull-based dinners. It looks a bit bougie, but it's actually pretty stressful. From what I've heard, cases are presented from interns all the way up to senior residents that present on management. We brought brain school, teaching neuroanatomy and skull-based anatomy to medical students. We started a campaign for national resident education, so we have 2 texts coming out. And our course, I think, to teach some of this, unfortunately, had to be canceled this year, but we're hoping that those who are listening on will join us next year in New York. All the costs are covered as well, and that's definitely one of our specific missions is in terms of education. But I think the most important lesson that I have for everybody is to be hungry and to be humble. I think it's very important to be very, very hungry in building a center, but there will always be people who are doing it better. They're doing bigger tumors, they're doing higher volume, or they're having more, and they have more experience. And so we learned from that, and it's a good thing because we turned to those people and those centers, many of them who are on the call now, the webinar now, and I think that just leads to growth of the center in general, and that's led to the success of our center over the last few years. So that's just a very short introduction. I'm actually very excited to hear from the panelists, world experts in their fields, and we'll go through UCSF and Dr. Theodosopoulos and Dr. Zimmer's experiences, Pittsburgh experience, and then the Michigan experience, and we'll save the questions all the way through the end. So without further ado, I'd love to transition to Dr. Theodosopoulos and Dr. Zimmer.
I hope I go first because I live in the best city of them all with the best weather, rather than because I'm the oldest one here, which I hope I'm not. But, well, I echo a lot of what you've said, and I think it is a process. The UCSF is a little unfair to describe the group as UCSF. Lee and I started many years ago, well, almost 2 decades ago at the University of Cincinnati. And then when I moved and Lee moved, we both have generated a second practice, a second group. So we've done it twice over. And I think, you know, a lot of what you said is true. It goes back to what Frank Mayfield used to say, the 3 A's: able, available, and affable. You have to do that. And to do that, you have to be well trained. And nowadays, it's a little bit easier to be well trained than when we were, because I think Lee was Amin's first fellow and Carl's, but you know, we didn't have a fellowship in endoscopic skull-based surgery back then. Now we do. You have to do cases. You have to, as you said, measure something. You know, Atul Gawande says that, and it's critical. Unless you measure something, you're never going to know if what you're doing is good. And then you have to publish, which means you have to study something. And this kind of iterative process takes a long time. You know, it took about 5 years, almost before the first paper came out of our group. And then, of course, a lot of other stuff come out. But it's key to focus on substance rather than just numbers. So what you do, measure what you do, and then talk about it and be honest. You know, I think both Lee and I, from the very beginning, were quite honest with our outcomes, although it was not always congratulatory. And I think that's where you learn, sharing those, and not sharing those that you know, saved from the jaws of defeat, but learn from those and share those that you actually were defeated big time and you just messed it up. Finally, I would say that, you know, outreach is critical for this, and what we have struggled, and I've seen this now in 2 different environments, and is the who do you work for? And it's one thing to work for a supportive chairperson, because that we all do, and hopefully all of the participants have a big support. But you know, it's the system you work for, what they're willing to do for you, the outreach to not just the neurosurgery world who you can reach with papers that we write and you send to the journals, but also to the medical world, the doctors around you, endocrinologists in particular for endoscopy are very important. And then also to patients, and how do you do all that? That takes money, that takes time. And the last thing I would say before I turn it to Lee is, you know, a perspective that maybe some in the panel would also have shared, but it's an older, much older perspective that we saw back at the beginning, is to do this, you have to really do this well. You know, we span the world of microsurgery into endoscopic surgery. I have never been taught endoscopy, and we kind of helped all of us together do some of it and advance it. But in doing so, a lot of people on because they tried to do it alone. So the concept of a team, and Vijay, I love this, the fact that you brought the teams here. The concept of initially doing it alone, a lot of neurosurgeons did this. And they said, well, you know, I do them by myself, which is virtually impossible, especially if you're not good at endoscopy, to do this by yourself. And then they tried, when they tried with ENT folks, they tried with the traditional ENT open folks that they would use to open the nose. And those people were not endoscopists. So it was a bloodbath very early on. And so they would take the scope out and they would put the speculum in and go back to the microscope. And I say this because this is not I have done this in the beginning. And you have to really change the mentality. If you're going to switch, and I don't know who the listeners are or who eventually will hear this, but a lot of neurosurgeons have been trained to do it microscopically, want to switch to endoscopy, and they find a difficulty there. And I think the most important part in that is to actually have a team, have somebody who is an endoscopist on the team, and to be willing to share these, regardless of the finances, which are not very promising when you do pituitary surgery to have 2 surgeons. But unless you do that, unless you do a lot of the simple cases together, you're never going to get the dance together, and you're never going to really get it going to the degree that is worth trying the more complex cases that have a lot more on the line. So with that, I would say, Lee, you say your view of this. I mean, we did this for a very long time together, so.
Yeah, I would add, Bill, that I think, is everyone hearing me okay? I'm hearing some feedback. Okay. So one of the things I think we can all look back on our careers, we're all very bright individuals, but we can look back in college and med school and remember mentors of ours that really pushed us. I know in medical school, in undergraduate, I started working in the lab at the University of Michigan doing electrophysiology, and those guys pushed me into the field of research and doing an MD PhD, which I did at the University of Cincinnati. My PhD advisor, who unfortunately passed away last weekend, was very vital in teaching me how to write, how to think in a research mind, which I give him a lot of credit for. He always told me, Lee, I don't like MD PhDs. You're only my second in 25 years, but your experience, so I'm giving you a chance. And it was a wonderful experience for me. And as a med student at UC for 3 years, John too, who was the president of the Mayfield then, was my MD advisor. And he was very helpful in guiding me in my medical school career. And when my PhD advisor moved to the University of Maryland to take the chair there in neuroanatomy and biology, John said, Lee, go to Maryland, do not stay at Cincinnati. So I transferred to the University of Maryland and finished my MD PhD with Mike Shipley. From there, I had the blessing of matching at the University of Pittsburgh at a very opportune time. And I know, Paul, you can agree with me on this. We were both there during that time when Amin and Carl and Rick were really pioneering endoscopic skull-base surgery and pushing its limits. And sometimes I'm sure they'll say even too far. But somebody has to do that. And in the world of otolaryngology, people will attest to individuals like Robin Cotton, who pushed the field of airway reconstruction sometimes too far, but learned from that. So I really was blessed with great mentors. Carl, don't get too pouty over there, but with great mentors, it really led what I thought about my career and where to go with it. And it's interesting for the younger individuals in the room, and Phil will attest to this. When I asked Carl, I said, "Hey, you guys need a phone." He goes, "Yeah, we've been talking about that." So I stayed at Pittsburgh an extra year. When I started looking around for jobs, people were like, "You do what? What is that?" So when I applied, I sent letters to about 40 different institutions, and I got 3 replies. University of Cincinnati, Loyola University, and University of Washington. So that's all that was offered to me from a broad base of places. Nobody was really on board and jumping up and down saying, yeah, endoscopic skull-base surgery. But Cincinnati was nice because it was my home. It's where I grew up. And my wife got an offer at the University of Children's Hospital in Cincinnati, which is kind of the mecca for a lot of children's hospitals in the United States. So we had an opportunity to go home and work at great institutions where I hooked back up with Dr. Tu. I hooked up with Dr. Theodosopoulos and Miles Penzak, my chairman there, who was exceedingly supportive of our roles to build this program. And we had a little, Phil will remind me, I call it the broom closet, where I was able to start doing anatomical work up in our department, and some of our first couple of papers came out of that. I was actually using zip drives to record. You know, the young people in the room might not even remember what a zip drive is, but I was using zip drives. And we had a Stryker rep named Jason King. Some of you guys might recognize that name, but he was our rep at the time. And Jason's like, you guys need better equipment. Let me get you some better equipment. So he actually got us the high-end Stryker system at the time back in 2005 in my little broom closet. And then Jason and I were talking about, well, what about building a lab? And Jason's like, well, I might be able to work through Stryker and get you guys a pretty good deal on some equipment. And then Miles, in his contract for becoming chair in 2005 when I joined, had some money set aside. So we were able to put together $1 million plus lab with 10 stations through the generosity of Stryker, Medtronic, the university, and Dr. Penzak's deal that he had as a chair. So that was fortunate. And that's something that junior people come out, that if you're going to a center that doesn't really have a lab, I find it exceedingly vital to have a cadaveric lab. I spent a lot of time, Phil can attest to it, my first 2 years there, because I didn't build a practice quickly. A lot of time working on cadavers and building up my own skills to where today I feel like I just see everything without seeing everything. So that was very important. So strong chairman leadership, working with industry, partnership with Dr. Tu and with Dr. Theo. And as Ricardo Corral, I'm sorry for the noise in the background. I'm not sure who's here. Who's quiet. That in some ways, some luck, we're able to build this program there. And, you know, being friends with your neurosurgeon is very important too. I mean, Phil and I became really good friends. Our wives became friends at the time. When Phil left, Dr. Norberto Andalus and I have become very close. We share FC Cincinnati tickets together. It's just that relationship and that bond between us, not only as surgeons, but us as people, is very important. And then finally, you know, when I left the University of Cincinnati, a part of that was to stay working with the Mayfield Clinic. And the Mayfield Clinic has a lot of resources also here in Cincinnati as a private group and a laboratory, which I've been taking advantage of with them. And it was a rebuilding process, yet again, I would say for the third time, with a third group of neurosurgeons, both of which I trained when they were residents and outstanding individuals. So, you know, working hard, relationships with your neurosurgeons, and Phil and I go back because we didn't have a lot of PR support from the University of Cincinnati. We picked up the phones, we talked to the referring doctors, we talked to the endocrinologists, we wrote letters. We did it the old-fashioned way by beating the drum. And I think a lot of people today forget that. They just send that letter in Epic. And even though that letter in Epic is important, it's not the same as talking to your referring doctors. So with that, I will turn it over and put myself on mute since all the family is getting home.
Yeah, thank you, Dr. Theodosopoulos, Dr. Zimmer. You know, sort of just as you were closing, there was this conversation happening in the chat box as well, and that was huge for us when we were first starting here, is we really had to convince providers that, you know, we could provide a service here internally. So they all had our numbers, would text us, consults would text us, oh, would you mind seeing this patient? And in the beginning, the majority of it was not skull base, but over time you develop confidence, and then they send you the chordomas and the skull-based tumors. And so Dr. McKean just gave a great sort of summary of their practice, which includes a lot of that as well. So thank you both very much appreciated. And with that, I would love to turn the floor to Dr. Gardner and Dr. Snyderman to talk about the Pittsburgh experience.
Let me unmute and we'll share our screen. We do have a couple of slides just to talk through. And obviously, are you guys able to see that screen share?
Looks great, Paul.
Okay. I may not be the best person to talk about 100% how to start a skull-based program, since I was fortunate to come into the longest running one in North America. But obviously, you always have to restart your own practice and your own portion of it. And I think that you know, one of the important things is that when you do start, you're not going to be doing all skull-based, and even when you get very far along, there's no such thing as Carl says as someone who's purely a skull-based surgeon. And so you build this, I think, as Vijay showed very nicely, with a combination of multiple different subspecialties that you do, whether it's within ENT or neurosurgery, whatever, regardless of the subspecialty. A lot, you know, my practice at this point consists of both skull-based as well as vascular. I know many skull-based surgeons who do a lot of general brain neuro-oncology. And when I started, I was doing any and everything, get my hands on, NPH, you name it. In your practice, hopefully that shrinks some over time. But I think it's part of being, you know, affable and available. And Carl, I don't know if you have thoughts about how, from an ENT standpoint, how those meld together.
So, you know, the most important thing is really team surgery. Skull-based surgery, more than any other discipline, is team surgery. And so having the right team is probably number one most important thing in building a good practice. And, you know, this can be done as a single or a multi-specialty team, but there are big advantages of having two different disciplines working together. We have our own distinct knowledge, domains, and skill sets, and it improves the care of patients. There's a lot that we learn from each other and take back to our own practices. We bring patients to each other. So I think that's the best marriage, you know, having two different specialties, but situation you may have to go it alone But even if it's a single specialty environment, you really need to have two surgeons working together. And then you need to watch out for warning signs. You need to have a team that is cohesive and functional. There are a lot of factors that may contribute to a dysfunctional team. A big difference in age, having a very senior surgeon and a very junior surgeon doesn't work out well. There's a power disparity there. You need to be flexible as far as your schedules, have similar philosophies about management of patients, and you want to avoid, disruptive personalities and those kinds of things. There's a great YouTube video noted here. I'm not going to play it, but I recommend you all go to it. It's by a comedy group, Webb and Mitchell, about egocentric behavior. And if you don't catch it now, email me and I'll send you the link. And then also, remember that we are diverse specialties. We deal with a lot of other different groups. It's not just ENT and neurosurgery. It's our colleagues in other areas, and there's a lot of collaboration. We work with the otologists, the oculoplastic surgeons, endocrine plastic surgery. Everybody benefits from collaboration. I've been very fortunate to be part of some great teams over the years, as pictured here. And here's our current team. One big advantage of having a big enough team is that there's duplication. It's nice to have a partner on the ENT side and on the neurosurgery side who can help you out. We can tag team surgeries. We can problem solve together. And I think it increases the quality of your care, having that added person to consult with.
That's a great point that Dr. Schneiderman makes about building your practice through other specialties. The cases that I do, certainly a very large percentage of them are ones that come in through other specialties, and that's I think Vijay really hit the nail on the head when he talked about that aspect of things. Of course, all the neurosurgeons here have struggled with egos of their ENTs. I mean, it's just one of the things you have to deal with. Everyone knows how difficult ENT can be to get along with. Fortunately, we're neurosurgeons are very nice people always, and that's never an issue. This is an example of how we perceive these teams being made up, and it's this combination of factors that are all necessary as part of the team. And a lot of times you have to build and rebuild these several times over to keep them robust and to build each part of it. And no skull-based team is made up of a single piece of this whatsoever. And I think that team aspect of things has been the secret, and really is the secret certainly to our success. There, of course, are hospital resources related to that. I think a lot of times if you have the cases, those get built. Certainly neuroradiology gains expertise at the same time as pathology, but you really have to have the support. Endocrinology is key. Support of a good endocrinologist can help build a pituitary center, which we'll talk about in a bit. But one of the things we don't often talk about as part of the team is the dedicated OR staff and equipment. Working with the same OR staff every day, day in and day out, can make the difference between you being able to do complex surgeries and not. When we talk a little later about learning curve in a moment, that your OR staff has a learning curve right along with you. I may be able to go out tomorrow and do a complex chordoma or an olfactory groove meningioma, but if I go somewhere that's never done it as an OR, I won't be successful and I'll have complications I wouldn't normally have.
There are lots of obstacles to developing a skull-based center. Most important issues are having a good team of surgeons and adequate expertise. You need to have adequate volume of cases to develop that expertise. You need to have a team of surgeons that's willing to work together and make the sacrifices that are necessary. When I look around at other centers that have had where their skull-based centers have sort of fallen apart, it's because the teams have broken up. Somebody moves on, and it's an unfortunate aspect of academic medicine is that we often move around for a different job. But the places that are able to keep a team together for a longer period of time are more successful in building their skull-based practice. There are logistical problems you need to work through. How do you run your clinics? Do you have separate clinics or a combined clinic? We have not found it productive to try to share clinics, but we have our clinics on the same days. So we can send patients back and forth. New patients can see us preoperatively in both departments at the same day. We make ourselves available on the same OR days. We work out of the same hospital, same operating rooms. We're available for post-operative care. So it really, depends on your environment, but you want to make effort to get rid of those obstacles. And then coding and billing. You have to be willing to make a bit of a billing sacrifice for the sake of your team. There's a departmental incentive to keep all the revenues within that department, but that's destructive for building a skull-based team. You need to share, and in aggregate, you will be better off in the long run. But as an individual, it may be temporarily decreased because you're not billing 100% of the case.
It definitely requires a commitment by every member of that team, both from a billing perspective, but also your learning curve is an important part of it. If you try to jump right into some of the complicated cases, you might end up with a carotid injury on a case you didn't suspect that you might run into and may not be prepared to manage that. And I think that's, going very slowly through a learning curve. And again, it's not just you as a single surgeon, but it's your entire team going through that learning curve. You get new members of the team, you have to go through that learning curve again, and you have to build that. And that does require both a time and a resource commitment. Here is an example of what we've put forth as the training levels for an endoscopic skull-based surgeon, how to progress through that. But you never stop with your learning curve, whether it's in microsurgery or in endoscopic surgery. The two are very complementary. And I think you should always be constantly trying to improve your abilities. Many people, I think, a lot of times would stop at a level 3, which is sellar surgery, extradural surgery. It's when you start going into the intradural surgery with endoscopy that the risk goes up. And then level 5, such as vascular things, I think is appropriately questioned whether anyone should be doing these endoscopically, and certainly should not be done until there is pretty dramatic experience. We looked at this recently to see a validation, and here you can just see the complication rates, length of stay, length of surgery, going up dramatically when you get to level 4 and 5, which is in green and purple, shown here on these training levels.
It's been said already, you can't change what you don't measure. And so you really need to look at your own data so that you can get better and be noticed by the community. So we track 3 types of events: our common event, which is a CSF leak, an almost never event, which is vascular injury, and then a system-wide event, which has economic repercussions, readmissions. Here's just an example of a run chart showing groups of 100 patients looking at CSF leak rates from when we started. And here's data for the last year. So we really are collecting data all the time, and you really have to do that. You need to be able to compare yourself to other centers. You need to have full disclosure to patients. They want to see this kind of data these days. And we send out emails to our skull-based team reminding them of how we are doing in these categories so that we can keep everybody focused on key factors. If we have a bad complication, we do a root cause analysis, try to understand and learn from that complication. And this becomes part of your daily routine. Quality improvement is a constant process which everyone is involved in, and we're constantly striving to improve our outcomes and the quality of care. Our latest endeavor in this area is to establish a pituitary center of excellence, which will increase our profile in the community, but more importantly, drives us to do more rigorous data collection and improve the care of our pituitary patients.
Really, if you can't emphasize enough, that avoiding complications, especially early on, you can definitely damage your practice and your reputation if you try to get too aggressive too early on. Once you do start to get a certain amount of facility and your team is up and running, certainly marketing becomes an important part of this. You want everyone to know that you're a skull-based center, whether that's obviously excellent patient care is the most important. Lee talked about individually reaching out to other physicians. Very important. It's something we forget, probably the most important for regional practice building. You can have a web presence, as many lectures as you possibly can. Publications is both an academic pursuit as well as a form of marketing. And then, of course, taking part in courses so others get to learn about your practice.
So just some parting thoughts. Why do skull-based teams fail? Some of these we've already talked about, working as a team. Don't take on things that are too difficult early in your learning curve. Having adequate resources and mentoring. Don't forget, you're very fortunate now to have a community of skull-based surgeons that span the North America, and you can reach out to those people within the NASBS. And if you're having a problem case or want to discuss a patient prior to surgery, or even if you get stuck with a complication in the middle of surgery, you're welcome to contact any of us and really ask for help and guidance. Just some follow-up resources for you. The things we've talked about today in otolaryngology clinics of North America, but also refer you back to the NASBS white paper on coding and billing, which is very helpful for sort of solving your institutional issues with sharing cases.
I think you'll see over and over again here, everyone with the theme of building a team. And the most important thing you do is find yourself a great partner. That makes life certainly more enjoyable, and certainly skull-based surgery practice can only build based on that. And thank you again, Vijay, for involving us in this. And I think it's a very important topic, and thanks for doing this.
Thank you, Vijay.
Yeah, of course. Thank you, Dr. Gardner and Dr. Snyderman. In a lot of ways, a lot of what we do is based off the Pittsburgh model. So lots of pearls there. So thank you very much. I know you guys are working late. So I thought I would just pose a question in case you guys have to jump back to the operating room. And I think it's a great question. If someone can be a good endoscopic and open surgeon, so maybe do some general ENT, and someone can do lateral and anterior skull base, or whether all that time should be spent really honing your craft in one subspecialty.
My personal opinion is that I think it partly depends on how you train. I do think if you can, and this I'm seeing more and more where people are training both simultaneously, and that's how I was trained. I was learning my micro skills. I didn't know how to work under a microscope any better than I did under an endoscope. I was learning them simultaneously, and I found a lot of the concepts actually crossed over. And so I really do think that if you commit to both, that they are very complementary, but it takes a pretty significant commitment to it. I do think it's possible. I think it's probably the preferred course for skull-based surgery, but I don't think that, for example, I think there are certain skill sets that do fit well. For me, I'm not good at glioma surgery or metastasis surgery. I'm not good at spine surgery. I've focused everything and given up reimbursement, given up shorter, better cases to some degree in order to commit to that. But that has led to me having a very narrow skill set, but I can switch from endoscopy. So I think it's possible, but only within those constraints. And I think the two build on each other.
Yeah, I mean, that's difficult. I mean, I'm a dinosaur these days because my training has included both, and very few people have that background anymore. But there's a great advantage in having a consolidated skull-based team that manages all the skull-based patients. If there's too much internal fragmentation within your institution, then there's a lot of competition for cases, and nobody has the volume to either become good at it or to really market themselves successfully as a skull-based team. We do open and endoscopic and adult and pediatric, same team. And I think that's better for patients. We choose the best approach for the patient. We can offer whatever operation that's best suited for that patient. But that's not the reality of how people train these days. So the alternative is to assemble a good team within your specialties, within your respective departments that are willing to work together.
As long as you're cohesive as a team, you can build that same kind of complementarity.
Great. Thank you, Dr. Gardner, Dr. Snyderman, very much appreciate it. And so the next on our panel is the Michigan experience with Dr. McKean and Dr. Sullivan.
Thank you. It's a nice transition. By the way, I want to say we are generally physically distant, but we are actually married. So being together is our everyday, both in the OR or out of the OR. And it was a nice transition. It was a great question because I was trained actually in open skull base, and then we went to the Pittsburgh course to learn endoscopy, same for Dr. Sullivan. And I see that I call him the boss, Larry Marentet, is on the call. Larry Marentet, Dr. Marentet and Dr. Ross created our University of Michigan skull-based program in 1994. So we're over a quarter of a century old and continue to build as a team. So much like the Pittsburgh group, we came into an established practice. So that's fortunate in terms of having those resources. The other fortunate thing for us today is there were a lot of great things already said, so we can be brief. So some of the tips we talked about sharing is about, again, building camaraderie for us. When we were building our practice, we started with going to the Pittsburgh course. So either a course to just build camaraderie, even if you have some skills, to work together, to learn how to work together, or get in the lab, do those things together to practice. I think that Carl and Paul already talked about, does your OR time and does your clinic time align? So you can be available, so you can see patients same day. It's really important. That's a big model that Larry Marentet set up for us, is us being physically together so the patient can hear a unified voice. You already talked about, does the skull-based volume support your entire FTE to be a skull-based surgeon? For most people building a practice, that's just not going to be true. Initially, you're going to have another practice that funnels into skull-based before you become 100% skull-based. And even for those who are mostly, even those of us who've been doing it for a while are not 100% skull-based, have other things to do. I think something that brings joy to us is active mentorship and sponsorship of each other's teams. I love working with the neurosurgery residents. I don't know how you feel about ENT residents, but I think we learn from each other, we train each other, we respect each other, and it brings a lot of joy to have that education. BJ, I think you said, talking about, having a theme of education, that's really important to us as well. I heard multiple talking about department alignment and incentive alignment. It's not just ENT and neurosurgery, it's ophthalmology, neuroradiology, that picture that you showed, Paul, about the whole team. All of those groups have to align. And sometimes the billing doesn't work, and sometimes the clinic space doesn't work, and the technology doesn't work, and we have to come up with a solution together. It's really important that you have buy-in from multiple departments to make that work. Same thing, vacation time, you don't want to be gone when one of your partners need to do a huge skull-based case. That's obviously not ideal. And what do you do with your patients when you are on vacation, when the whole team's out? Who's your backup? So I think at the end also, I heard talking about redundancy in the system. That's a mistake that we've probably made. We would love to have more redundancy in our system, because otherwise we end up operating a lot on vacation or evenings and weekends, and that's just what it is. Research expectations and support might be different, but if you really want to build a solid research team, it's something to think about. And who's the final decision maker? So I think many of you have heard this story before, but I know when I get too far and I apologize for those who've already heard it, when he tells me, have you ever caused a hypothalamic infarct? I know that's enough. That's where I stop. That's his territory. When it comes to managing malignancy and understanding the guidelines for malignant disease, that's my territory. When it comes to vascular injury, that's more of his territory, although it's a work in progress. And the other thing that we realized over time is if we do have care pathways and treatment algorithms where we come to a common understanding before a decision is made about how we're going to make that decision, that can just help ease the process. Another theme with the team, just learn together each day. And we debrief after each case. How did that go? What could have been done better? What was done well? And we learn from each other. I learn a lot. I'm not a neurosurgeon. I certainly don't know what he knows, but and he doesn't know what I know about ENT. But we could actually, at this point, know a lot by just talking about the cases. Okay, if I do this one too. This is the only point that I think is different that I really kind of wanted to put for longevity's sake, and as we're building diversity in skull-based surgery, which I think has been an issue. I think we're talking about how to build a practice, knowing that our audience for many people are junior faculty. But I think if you want to play the long game, not the short game, avoiding burnout is important, and it's very easy to get to a place of burnout in a subspecialized field where you're dealing with rare cancers and you have a unique skill set. So how does this play out? I think this may resonate with a lot of you, but some of us, we get into these fields and experience imposter syndrome, where we feel like you walk into the NASBS and there's these amazing people that you've read about and they've done these great things, and you think, oh God, I can never be them. Do I fit in here? Who am I? And maybe you don't look like them, and when somebody asks you to participate, you're like, oh, I'm in, I want to be a part of this. And there is somewhat of a diversity tax, both organizationally, so for women and minorities, you're often asked to do things, which is great, but that adds a lot to your schedule. And same with rare expertise in your institution, right? We're doing unusual, rare things, and you might get pulled into billing and coding and management of your care units and nursing systems and OR systems. And so that rare expertise and diversity tax, I'll call it, your imposter syndrome says, I got to do this. You feel like you want to, you feel like you want to represent, and it can be a heavy weight for women and minorities when they don't see people who look like them, to feel like, I want to kick this, I want to do the best I can because I want to represent my group well. So those kind of go hand in hand. And then if you add into that, which I think a lot of us have, an element of obsessive compulsive perfectionism, you are bound to burn yourself out. So thinking of this as a group, I'm not saying this, by the way, for those of you who this doesn't fit, I'm not saying don't ask people of diverse backgrounds to participate. Very much do. But be aware of what resources and structure they might need to support them. For those of you this doesn't apply to. For those of you it does apply to, I think thinking about things that can prevent burnout, like making sure you have meaning and purpose, making sure you have departmental resources, making sure that you have backup in your team and colleagues who can cover for you, I think is helpful. And I have clearly spoken the whole time. Steve, would you like to say anything else? I think that's it.
I guess I'll just talk to the younger people who are listening to this web. Well, what's the first step in making this career? How do I find a job? How do I get something up and going? And there's no perfect answer to that. Very few of us are fortunate enough to find ourselves in the degree of infrastructure and collaboration that, say, Pittsburgh had. Now, they had to start it as well, and that was a lot of work for many, many years. And the people who are doing it now are reaping the benefits of that. But a lot of places will not have anything like that. We had the luxury of an excellent ventral skull-based program of Larry Marin-Tetz and an excellent pituitary program. And we were able to build upon that. So that was our advantage. And I've never really forgotten that. But if you find yourself in a position that you just starting everything from scratch, it's not ideal, but nothing ever is. The enemy of good is perfect. You need to identify people very early on who can be your allies, be your partners, as has been mentioned before, either with oculoplastics or with ENT. It's nice to get a match in a roughly similar career zone, because you'll find that your goals are similar, and develop allies with the other faculty, because people will sometimes think you're crazy when you start doing this stuff. Why are you doing this stuff? Why are you doing these operations through the nose? And if you develop political alliances, and I don't mean that in a callous way, but really just people who you trust and who trust you, and really work on that. And you can talk to a senior guy who's never seen an endoscope and get his or her trust. And then when you're ready to do these big cases, you talk to them. And if you have a complication, God forbid, they're going to be there to back you up. Conversely, if you just go in like a bull in a china closet and just say, I'm the best thing on, on two legs, I'm just going to show these old guys how to do it. And you run into trouble, you're going to be hanging out in the breeze, and that's a tough place to be in. So be patient. Realize that it's a long haul. There are always bumps. Nothing is perfect, and develop the sorts of relationships early on that can foster you, and you'll get there. You're not going to be doing nothing but paracellular tumors and craniopharyngiomas from day one. It takes 10 to 20 years to get to a practice like that. So be patient. That's all I have.
Thank you, Dr. McKean, Dr. Sullivan. Very much appreciated. I thought we would just dive right into questions. I'm getting some. Thank you for answering them in the panels. The first one's actually for Dr. Theodosopoulos and Dr. Zimmer. This one strikes a chord with us as well because being in New York, and Ted Schwartz have been more allies than they have competition. How important is it to foster collaboration with local academic centers? So with a Stanford in the area, Allegheny and Pittsburgh and NYU, New York. Dr. Theodosopoulos, how do you feel about that?
I think you can't go without it, frankly. You can try to do it without it. In 20 some years I've been in neurosurgery, all the people that have tried to go without collaborating have not really gained as much traction and certainly have failed in bigger endeavors. There's no market big enough to and small or isolated enough to be at it alone. And I think multiple of the speakers already have talked about you want to be able to bounce things off other people. You want to be able to share the misery that sometimes comes with this. In skull-based in general, look, I do more open skull-based than endoscopic skull-based. These are lessons that I think most of us have learned one way or another. But, and you should know your limits. Going out, I think somebody said, going out and starting with an intracranial endoscopic approach is just the wrong thing to do. I think you have to have a team that's very comfortable doing the simpler things. I think Paul and Carl's algorithm is a very good one in terms of how to advance. And that means that in the process that you're building it, you're sending those cases to somebody else, or even going there and observing the case while they're doing it. I mean, you can learn. I've had a lot of visitors come and be in the OR with me, and I welcome that because I think that is what builds relationships that, look, you don't build big, Suzanne Chang, the best neuro-oncologist in the country who I have a pleasure of working with now, and I've known for a long time, had taught me this about glioblastomas. You don't build a malignant glioma program by giving temozolomide or, Avastin. You build it on trials. So you have to support the people out there in the standard treatment, have them do it, and send the complex cases into the other places and slowly build your own program. But understanding that your limits is probably the most important thing in getting into this, because it will take one bad complication, and not only you would be kind of under a lot of stress from your own department, but your reputation can go down. So that's not a good thing.
Let me add into what Phil has said. This is Lee Zimmer again. I think there is probably one case that Phil and I took on, I wouldn't say early, I think we took it on fairly late, but it was a fairly large juvenile angiofibroma, Phil, if you remember this, and a very young kid, I think he was 12. And we did a stage 1, we watched the blood loss. We didn't have a complication, which was great, but we thought we really did a good number on this tumor with a stage 1. We restaged him for the second operation and got a new imaging, and it looked like we did nothing on that imaging. And quite honestly, from there out, when we saw tumors that big, and even though we were doing expanded transfemoidals at the time, but I felt best. I think Phil agreed. And when Phil left, I certainly followed this. I would send the patients up to Ricardo Corral in Columbus or up to Carl in Pittsburgh when they came by my desk. And we had the unfortunate thing at the University of Cincinnati that Children's Hospital is a separate entity. It's not owned by the university. And so they felt that any stage 1, 2 juvenile angiofibroma they could do. So they wouldn't let us get our experience up on the easier JNAs. They would send us the big ones that are wrapped around the carotid with intracranial extension. And so we never had the opportunity to really build a good experience with a large vascular tumor like that. So I just felt it best, and I still do today, of referring those patients out to the individuals. And you can thank me, Paul, that I send those to you guys to take care of. But I just feel that's the best thing to do.
Thank you very much. Next question, actually, we're really lucky to have our rhinologist, Dr. Akbar. He leads our interscope-based program. Dr. Moskowitz, he leads our lateral skull-based program, and interestingly enough, trained at Michigan and Pittsburgh. So lots to think there. Is it necessary to do a skull-based fellowship to start a program?
I think it's actually quite helpful to do a fellowship. There are obviously lots of reasons to do a fellowship. Obviously, doing more cases enhances your skill. You get to do more cases, more complexity than most cases you have in residency. You also get dedicated time, which you don't always have during residency. Furthermore, you get to have a decision-making process of a leader in the field that hopefully you had during residency, but you get that extra benefit during fellowship. Nadeem, you want to?
I would just echo what Dr. Moskowitz said. I mean, doing a fellowship, you come out of residency having a pretty solid skill set, whether you're an ENT doing endoscopy or skill sets that neurosurgeons have coming out. But the refinement that you get doing a fellowship, I think is, I mean, you can't replace that. Again, and like you said, you have mentors that you'll be able to call middle of the night if you're in a case, getting a complication, people that you can rely on for not only surgical knowledge, but also practice building knowledge or how to manage a difficult patient. So that I think makes a big difference.
Great. This next question is for Dr. McKean, Dr. Sullivan, and actually one I want to open up to the panel as well. A couple of people emailed me, and for us it was a big deal here, how COVID has affected your skull-based practice and how have you recovered volume safely. I missed that last word, very important. How have you recovered volume safely?
It's been a struggle. I mean, I can't say we're experts on it. It was, as I suspect everybody felt, it was a day-by-day situation. I remember when it first started, I remember talking to Ted Schwartz, and he was right at the beginning of that surge, and none of us knew where this was going, And when it finally hit Michigan, we were told we had to stop all of our elective procedures, and I did. I stopped everything. But the question is, what's an elective procedure, right? If you're going blind from an adenoma or a meningioma, is that elective? Well, I canceled a lot of those patients. And a few weeks later, when things did not become as bad as was predicted, I really felt like I had not advocated for my patients. It was, at the time I thought I was doing the right thing, but in retrospect, I'm not really sure I did. And then we had a huge backlog of people, primarily with neurologic dysfunction. I sort of decided, if someone was having any visual dysfunction at all, I was going to call it an emergency because it felt like I needed to start advocating for people. And man, we were busy. I mean, it was just nonstop trying to catch up. And at the time, we weren't able to get good, quick COVID testing. We were wearing N95 masks. Aaron was in the PAPR all the time. Our workflow was horrible. I mean, everything was super painful, super slow. We couldn't even hear each other. Couldn't hear each other through those masks. So as we've slowly ramped up, we're not back to normal, and our institution, frankly, is not making it that easy to get back to normal. So I personally have consolidated my practice pretty dramatically to just doing pituitary surgeries because I don't feel like I have the access to the OR to be doing big meningiomas in particular. So that's how I've adapted to this current time of OR restriction. Now, that'll probably change over time, at least I hope. But I don't think that I've done it perfectly. It was a very stressful time. I'm sure everybody on this panel can agree. And some people are doing it better than obvious. I mean, Paul and Carl are operating, obviously, and we're sitting here on vacation. So some people are busier than others, but it's been a struggle. I don't know if it's going to get back to normal. We'll have to see. You know, there may be some permanent changes in our practice pattern as a result of this. Only time will tell.
Here in New York, we definitely see that as well. Any of the hospitals here will recover. Practice patterns, I think, are going to change permanently. But I would love to sort of hear from the panel as well. You know, Dr. Gardner, Dr. Snyderman, how you guys have resumed your practices safely and the measures you took to mitigate risk to your staff and everybody in the room.
We did the same thing where we sort of stopped everything initially, except for, you know, urgent cases. And we also did a survey of sort of global survey of surgeons that we could get in touch with to see what other people were doing, especially in countries that had dealt with COVID ahead of the US. And I think that kind of has led to some degree to what is the natural thing to do, which is you test people, as many people as you can, as close to the time of surgery as possible. And certainly ramping up testing has been a big part of, I don't know that there's any science behind that, but it's been a big part of surgeon and OR staff comfort, which is a huge part of it. And then appropriate availability of PPE. I think we feel as long as we're wearing an N95, our institution reprocesses them. So we use them 3 times. We use reprocessed N95s, but we all have them for any case that, for any endonasal or any skull-based case that traverses a sinus. So that's been our basic protocol for it. And I think that, I mean, we have been able to get back up to pretty close to volume with that, as evidenced by the fact that we haven't made it home to do this. But I don't know, Carl, your perspective on from the ENT side, because obviously an outpatient setting affects ENT as well.
Yeah, I mean, we share everybody's concerns. We actually went to the lab and did some studies with the residents looking at aerosol generation and convinced ourselves that as long as we've got suction in the nasal cavity, the risk of aerosolization is very low. And you know, we're not doing things that can be put off, but we're not delaying cases that might be to the detriment of the patients. And we're fortunate our leadership has been very proactive in addressing these issues and has encouraged us to, you know, get back to work.
Yeah.
I'd love to hear the UCSF and the Mayfield experience on that as well. It seems to be a real popular topic.
Well, you know, we stopped all surgery, pretty much more than 90% of all surgery for almost a month. And then we slowly trickled up again. And it was funny because we kind of reacted more. We were one of the first places California was, especially Northern California, to get patients after Seattle. And then it kind of petered away, and we never really were hit, knock on wood, up to now with a big hit. But, you know, we went to less than 50% occupancy in our hospital. And I mean, there's finances involved with this. You know, UCSF lost close to $700 million already, and the re-up of the cases has been slow. And we do use N95 masks endoscopically when we do cases, but we're trying to get back to normal, even without having large numbers in Northern California, despite California being the #1 place. And despite being open again almost completely, then, you know, we're not back at that level. Patients are worried about it. Staff, I think that what Paul said is critical. Staff being able to feel comfortable in those cases are not quite there yet. And so it's a struggle in many ways. And I think setting up a practice like that is, I think, really hard in an environment like this. But being safe trumps it. Now, having said that, leading the response to the OR, I can tell you that according to the American College of Surgeons, basically all neurosurgery is tier 3, meaning should be done. So I think what we have totally overreacted in this, and yes, we can be more nuanced, and there's been studies, and we published the first thing out on COVID response in the Red Journal. But I think one has to be thoughtful, and I think delaying surgery for, if it's purely elective, sure, but if it's not, then I think there's no end in sight. You don't know when it's going to be any safer. So these are not diseases that should wait, in my opinion.
And from our experience at Mayfield and Bon Secours Mercy Health is, again, that first month, we basically shut everything down unless it was an emergency. That first month, all I was doing was head and neck cancer and acute spine, where my Mayfield guys were revisions that they wanted my help on exposure. We didn't do a single pituitary that month. We had about 6 or 7 cases that were slightly compressing the optic nerve, but weren't emergent. So we as a group decided to hold off on those cases. We were certainly low, like everybody else, on N95 masks early on. As we got those back and we got testing up and running, we realized that really any nasal case, even despite negative testing, we just presume that they're positive. So intubation is always done with no staff in the room, except for anesthesiology, and they're in full gear for that. And then there's a 5-minute waiting period before we're back allowed in the room. Where our N95s, the surgeons and the lead tech, so the people closest to the nasal field, are all on N95. And we've been doing that now since probably mid-April. Volumes are coming back up. Our elective ENT volumes just are horrible right now. And people who are otolaryngologists probably know that. I think people just are too scared to go out if their nose is stuffed or having facial pressure. They're just not coming back. But our skull-based volumes are back up. And I'm glad to say that we as a group for otolaryngologists never stopped seeing patients in the OR. We consolidated to one office because volumes dropped. One doctor, 1 day a week. We're now back up to all of our offices being open. We're cutting down on how frequently we see patients to keep the waiting rooms low. In those 4 months, our 5 offices in our system, we've had no breaks in our offices. No surgeons have been infected. In fact, one of my docs was COVID positive back in early March. He was the first patient at our West Hospital system. Fortunately, he's 34 years old and just lost his sense of smell. That was it. So I think we're doing the right thing. We are careful. We don't suction in the office. We don't do a power instrumentation in the office right now because we don't have negative pressure rooms, which we're slowly getting from the system. We have to do post-op debridements in the hospital, which the patients hate because they have to be COVID tested again before they can come in and re-quarantine for 5 days. But it's working out and slowly progressing. But I think that our washing our hands, wearing N95s, wearing masks all the time, wearing face masks, face shields in the office has been more than enough to prevent problems with our daily activities. So hopefully volumes get back to where they were. I think they eventually will. But right now, just taking appropriate steps, because as you all know, we can't really rely 100% on a negative test on any of them. And certainly the rapid tests even have a higher false negative rate. So you just have to be smart and protect yourself, and at the same time protecting your patients when they're in your office.
Thank you to all the panelists. I just want to very briefly share a couple of slides before we finish. Like I mentioned before, I think the Skull-Based Society has been instrumental in my career and in all of our careers. And it's very important, I think, to have that support, like all of the panelists pointed out. And it really is for all the specialties within Skull-Based. So if you haven't, please apply. Mentorship program, which we've started, multi-specialty. We match you with someone, senior surgeon in your specialty, with your interest to help you with fellowship and career advice as well. And our matches grow every year. We'd love if you join this early or later in your career as well. And hopefully when travel improves, we can get back to this. This is an excellent program from the Skull-Based Society. Again, I just wanted to thank all of the panelists. There are a lot of reasons that people who are listening got into Skull-Based, and just as a team Skull-Based, it's a team to put this on. So a big thank you to Paula, Catherine, and Alondra. There's no way we could do this without NASBS and the group as well. And thank you again to the panelists, but I think this is a good time to to wrap up. And if anybody has any questions, please feel free to email us, and be happy to get back to you as well. Thank you again to everybody.
Thanks, Vijay. Good job.
Yeah, thanks, Jay. Appreciate everyone.
Thanks.
Nice halo, Paul. Looks like you're an angel out there.